We'll be starting with the section 8 of your Apurba Sastry Essentials of Microbiology, which is about respiratory tract infections. In this section, we'll be discussing the chapters Infective Syndromes of Respiratory Tract, Bacterial Pharyngitis due to Streptococcus pyogenes, Pharyngitis and Diphtheria, bacterial lobar pneumonia due to pneumococcal pneumonia, Haemophilus influenza pneumonia, and others. Bacterial atypical interstitial pneumonia, in which we'll be discussing Mycoplasma, Chlamydia, and Legionella. Tuberculosis and non-tuberculous mycobacteria infections, pertussis by Bordetella pertussis, infections due to non-fermenting gram-negative bacilli, myxovirus infections of respiratory tract like influenza, parainfluenza, mumps, respiratory syncytial virus, etc. Then coronavirus infection including COVID-19, miscellaneous viral infection of respiratory tract like rhinovirus, adenovirus, infectious mononucleosis, Epstein-Barr virus, and lastly we'll be discussing the parasitic and fungal infections of the respiratory tract, which will cover parasitic infection by paragnomias and others, and fungal infections like zygomycosis, aspergillosis, pneumocystosis, and others. Okay, this is a CBNAT machine, cartridge-based nucleic acid amplification test. This is this has revolutionized the TB diagnostics and treatment. It has turnaround time of 2 hours, also detects rifampicin resistance, and best for extrapulmonary specimen for TB. Now we start with chapter 59, which is an overview about infective syndromes of the respiratory tract. In this chapter, we will be discussing upper respiratory tract infections, oral cavity infections, and lower respiratory tract infections. Introduction. The respiratory tract is divided into two segments, the upper and lower respiratory tract. The upper respiratory tract includes nasal cavity, paranasal sinuses, pharynx, throat, epiglottis, and larynx. The lower respiratory tract, LRT, comprises of trachea, bronchi, which are divided into bronchioles and lungs, which with the surrounding pleura. Normal commensals. There are a number of bacteria that reside in the upper respiratory tract, oral cavity, and nasopharynx as indigenous flora. Some of these organisms are potential pathogens elsewhere in the body and may invade the respiratory tract under certain circumstances. Previous damage by a viral infection, low host immunity, or physical damage to the respiratory epithelium, example from smoking. Respiratory commensals. Common examples of respiratory commensals are Streptococci, alpha and non-hemolytic, Neisseria, like non-pathogenic species other than Neisseria gonorrhea and meningitis, diphtheroids, Moraxella catarrhalis, coagulase negative staphylococci such as Staph epidermidis, anaerobes like Prevotella, Streptococcus, and Fusobacterium. Major pathogens of other body sites may colonize in the nasopharynx less frequently, such as Haemophilus, Meningococcus, Pneumococcus, and Staph aureus. In hospitalized patients on the ventilator, the organisms present in the hospital environment, such as gram-negative rods, Acinetobacter, Pseudomonas, Burkholderia, and Enterobacteriaceae may colonize the upper respiratory tract. Yeast, such as Candida albicans. Now, the defense mechanism of the respiratory tract serves as a portal of entry for a number of pathogenic organisms. Encounters between microorganisms and the respiratory tract occur several times a day. However, establishment of infection after such contact tends to be the exception rather than the rule. This is due to the defense mechanisms provided by the respiratory tract which prevent the establishment of infection. Nasal cavity. Nasal hair convoluted passages and the nasal turbinates capture large inhaled particles before they reach the lower respiratory tract. Secretory products, secretory IgA and non-specific antibacterial substances, lysozyme in the respiratory secretion. Tracheobronchial tree, the branching architecture of the tracheobronchial tree traps particles on the airway lining. Mucociliary clearance, cilia and mucous lining of the trachea helps in clearing or killing the potential pathogens. Reflexes such as coughing, sneezing, and gag reflex offer the critical protection from aspiration. Normal flora of the upper respiratory tract prevents colonization by pathogenic organisms in the upper respiratory tract by several mechanisms such as competing the space for space nutrients through production of bacteriocins and other metabolic products that are toxic to invading organism. Alveolar macrophages, after escaping the upper respiratory above described defense mechanisms, the pathogens of upper respiratory tract can establish infection locally, whereas the pathogens of lower respiratory tract can gain access to the lungs. In such a case, the establishment of infection can be prevented by alveolar macrophages, which ingest and subsequently destroy the organism. So let us see the upper respiratory tract infection. The various URT infections, URTI, and the common microbial pathogens implicated are listed. The classification of microbial infection into URTIs and LRTIs is artificial, as many URTI pathogens can occasionally infect lungs, such as Bordetella pertussis, influenza, coronavirus like COVID, etc. Now, the upper and lower respiratory tract infections and the major pathogens implicated. Upper respiratory tract infections, pharyngitis and tonsillitis by viral influenza coronavirus and bacterial by staph pyogenes and Corynebacterium diphtheria. Laryngitis by influenza parainfluenza virus, acute laryngotracheal bronchitis, Croup by parainfluenza virus, epiglottis by Haemophilus influenza B, parapharyngeal virus, peritonsillar abscess quinsy by staph pyogenes, staph aureus and anaerobes, and Ludwig's angina by polymicrobial and anaerobic. Infections of nasal cavity and sinuses, rhinitis, rhinovirus and others, atrophic rhinitis, ozina, Klebsiella ozini, rhinoscleroma, Klebsiella rhinoscleromatis, and sinusitis by staph pneumoniae and Haemophilus influenzae. Streptococcus pneumoniae and Haemophilus influenzae. Now, infections of the oral cavity by stomatitis by herpes simplex virus, oral thrush by Candida albicans, dental periodontal infections by anaerobes and viridin streptococci, and salivary gland infection by mumps and others. Vincent's angina by Borrelia vincenti and Fusobacterium. Now, the lower respiratory tract infection like bronchitis by respiratory viruses, bronchiolitis by respiratory syncytial virus, whooping cough pertussis, Bordetella pertussis, and in pneumonia, lobar pneumonia by pneumococcus, Haemophilus influenzae, staph aureus, Klebsiella pneumoniae, and other gram-negative bacilli, atypical pneumonia by mycoplasma, chlamydia, and viruses. Pulmonary tuberculosis, Mycobacterium tuberculosis, rare cause of LRTI, fungal pneumonia by Pneumocystis jirovecii and others, and parasitic lung disease by Paragnomius ascaris and others. Lung abscess, primary by anaerobes and secondary by gram-negative bacilli. Pleural effusion and empyema by bacterial, secondary to pneumonia, tubercular and viral. The classification of microbial infections to URTI and LRTI is artificial. Many pathogens causing URTI can occasionally infect lungs and cause LRTI such as Bordetella pertussis, influenza virus and coronavirus, etc. At the same time, many pathogens causing LRTI such as Mycoplasma pneumoniae and Chlamydophila pneumoniae may occasionally cause URTI like pharyngitis. Pharyngitis and tonsillitis. Pharyngitis or sore throat refers to the inflammation of the pharynx, one of the most common upper respiratory tract infection affecting both children and adults. In children, most often it presents with tonsillitis, inflamed tonsils. Etiologic agents. Pharyngitis has varied etiology and most frequent organisms involved are bacterial agents like Streptococcus pyogenes, Corynebacterium diphtheria and other beta hemolytic Streptococcus group C and G are the major agents. Other rare cases include Arcanobacterium hemolyticum, Fusobacterium necrophorum, and Mycoplasma pneumoniae, usually associated with cough. Neisseria gonorrhoeae due to orogenital and sexual contact. Now, viral antigens, respiratory viruses account for the majority of pharyngitis cases. Viral pharyngitis should be suspected if concurrent manifestations such as conjunctivitis, coryza, cough, skin rash, vesicles on pharynx, etc. are associated. Etiological agents include influenza and parainfluenza virus, coronavirus including the virus causing COVID-19, Epstein-Barr virus cause infectious mononucleosis, enterovirus, Coxsackie-A virus, vesicular pharyngitis or herpengia, ecovirus and enterovirus 71. Less common agents being adenovirus, rhinovirus, herpes simplex virus or HIV as acute retroviral syndrome. Now the clinical manifestation, throat. Pharyngeal pain is the earliest symptom recognized when the person complains of difficulty in swallowing or drinking. Pharynx becomes erythematous, red and swollen. Depending on the causative microorganism, different tissue response may be observed. Enlarged and inflamed tonsil are consistent finding in children. Inflammatory exudate, fluid with protein, inflammatory cells and cellular debris seen in bacterial infection such as staph pyogenes. Membrane over the tonsils can be seen in diphtheria, pseudomembrane, rarely in infectious mononucleosis. Vesicle small blisters are seen in herpes, while mucosal ulceration or enlarged nasopharyngeal swollen lymph nodes are seen in infectious mononucleosis. In this figure, we can see a healthy throat and a sore throat with inflamed pharynx with enlarged and inflamed tonsils and uvula. Now, pathogenesis. Pathogenic mechanisms differ and depend on the organism causing the pharyngitis, either toxin-mediated Corynebacterium diphtheria or through liberation of several virulence factors like staph pyogenes or by direct invasion Arcanobacterium. Agents of bacterial pharyngitis are discussed later and agents of viral pharyngitis also will be discussing. Now, laryngitis. Acute laryngitis, inflammation of the larynx, has an abrupt onset and is usually self limited. The patient presents with hoarseness and lowering or deepening of the voice. Viral agents. Acute laryngitis is almost exclusively associated with viral infections such as influenza, parainfluenza virus, rhinovirus, adenovirus, coronavirus, and human metapneumovirus. Bacterial agents may rarely cause laryngitis. Presence of exudate or membrane on the laryngeal mucosa, streptococcal infection, mononucleosis, or diphtheria should be suspected. Treatment. Only symptomatic treatment is required. Antimicrobial therapy is not indicated. Chronic laryngitis. Occasionally, the symptoms last for more than 3 weeks. It is most often caused by vocal abuse, less frequently caused by infections. Acute laryngotracheobronchitis, CRAUP. CRAUP is potentially more serious disease as the infection extends downwards from the larynx to involve the trachea or even the bronchi. Agents. Parainfluenza virus are the major etiologic agents. Other cause include influenza virus, respiratory syncytial virus, adenovirus, rhinovirus, and enterovirus, and bacterial agents such as Mycoplasma pneumoniae. It commonly occurs in young children less than 3 years of age. In this figure, we can see the normal and inflamed larynx. Now, manifestation. Illness is characterized by variable fever, inspiratory stridor produced by turbulent airflow through a partially obstructed larynx, hoarseness, and a harsh barking non-productive cough. In young infants, severe respiratory distress and fever are common symptoms. Treatment. Only symptomatic treatment is required. Antimicrobial therapy is not indicated. Epiglottis. Epiglottitis is an infection of the epiglottis and soft tissues above the vocal cords. It can lead to significant edema and inflammation. Agents. In contrast to laryngitis, which is primarily caused by viruses, epiglottitis is usually associated with bacterial infection. Haemophilus influenzae type B is the primary cause of epiglottitis, although its incidence is greatly reduced because of widespread vaccination. Other commonly implicated organisms include Staph biogenes, Pneumococcus, and Staph aureus. Children 2 to 6 years of age are commonly infected. Manifestation. Children typically present with fever, difficulty in swallowing because of pain, drooling, and respiratory obstruction with inspiratory stridor. It can be life-threatening if the patient's airway gets obstructed. Diagnosis. Bacteriologic culture of the epiglottis is contraindicated because swabbing of the epiglottis may lead to respiratory obstruction. Blood cultures may be performed as H. influenzae bacteremia usually occurs in children with epiglottitis. Treatment. Cefotaxime alone or ceftriaxone vancomycin are the primary antibiotics given. Tracheostomy may be needed in the case of respiratory obstruction. Now, parapharyngeal infections like peritonsillar abscess or quinsy. It's a deep neck infection that occurs as a complication of tonsillitis. It usually affects children more than 5 years age and young adults. Unless promptly managed, it can spread to adjacent tissues as well as erode into the carotid artery to cause an acute hemorrhage. Organisms. The common organisms implicated are S. pyogenes, Staph aureus, viridin streptococci, and non-sporing anaerobes such as Fusobacterium necrophorum. Treatment includes surgical drainage plus antibiotics such as piperacin, tazobactam to cover the common etiological agents. Ludwig's angina. Ludwig's angina is a form of diffuse cellulitis of the mandibular space, bilateral, present in the floor of the mouth, subsequently may spread to sublingual and submental spaces. It was first described by German physician von Ludwig in 1836. Source. This infection most commonly arises from an adjacent dental infection, typically from an infected second or third molar tooth. Etiology often polymicrobial and anaerobic. Some common organisms associated include viridin streptococci, staphylococci, peptostreptococcus, prevotella, porphyromonas, and fusobacterium. Manifestation. It is aggressive, rapidly spreading cellulitis without lymphadenopathy with potential for airway obstruction. Present with bilateral lower facial swelling around the mandible and upper neck. Elevation on the floor of the mouth may be seen due to sublingual space involvement. Posterior displacement of the tongue may occur, creating the potential for a compromised airway. Other symptoms may include painful neck swelling, tooth pain, dysphagia, shortness of breath, fever, and general malaise. Treatment comprises of sufficient airway management, early and aggressive antibiotic therapy, incision and drainage of the localized abscess if any, and adequate nutrition and hydration support. Infections of the nasal cavity and sinuses. Rhinitis, also called as common cold, is an inflammation of the nasal mucous membrane. It clinically presents as a running nose, sneezing, inflammatory edema of the nasal mucosa, and watery eyes with variable fever. Rhinitis is typically associated with viral infections. Viral agents like 20 to 25% rhinovirus are the most common cause. Others include coronavirus, influenza virus, adenovirus, parainfluenza, respiratory syncytial virus, and enteroviruses. Bacterial agents 10 to 15% associated with rhinitis include Chlamydophila pneumoniae, Mycoplasma pneumoniae, and Streptococcus pyogenes. Atrophic rhinitis or ozena. It is caused by Klebsiella pneumoniae subspecies ozeni, characterized by chronic foul-smelling mucopurulent nasal discharge affecting elderly people. It is biochemically inactive organism. Ciprofloxacin or levofloxacin is given for 2 months. Rhinoscleroma. It is caused by Klebsiella pneumoniae subspecies Rhinoscleromatis. It is a rare form of chronic granulomatous hypertrophy of the nose. It presents as a tumor-like growth which may cause prolonged nasal obstruction. Infection may be spread to the sinuses and occasionally the pharynx and larynx. It is prevalent in Southeast Europe, India, and Central America. Treatment ciprofloxacin or levofloxacin is given for 2 to 3 months. Sinusitis is characterized by inflammation of the lining of the paranasal sinuses. Etiology acute bacterial sinusitis. The common pathogens causing sinusitis are Streptococcus pneumoniae, most common 33%, Haemophilus influenzae 32%, and Moraxella catarrhalis 9%. Less commonly, Staph aureus anaerobes and Staph pyogenes are implicated. Staph aureus, Streptococcus pyogenes are implicated. Staph aureus is common pathogen in sphenoid sinusitis. Viral sinusitis. Viruses account for 15% of the sinusitis. The common URT viruses such as rhinovirus, influenza, parainfluenza, and coronavirus are the primary viral pathogens in the acute sinusitis. Fungal sinusitis, allergic fungal sinusitis, although rare, may be seen in infection with fungi such as Aspergillus, Alternaria, Bipolaris, and Curvularia. Clinical manifestation. Common features are facial pressure and frontal headache, loss of smell, nasal congestion, and post-nasal drip. Additional findings depend upon the etiology. For bacterial sinusitis, fever, maxillary toothache, pleural and nasal discharge, and unilateral facial pain. Symptoms typically last for more than 10 days. Viral sinusitis improves 7 to 10 days. For allergic rhinosinusitis, post-nasal drip, sneezing, itchy eyes, headache, tearing, and red eyes, etc. are there. Diagnosis. Microbiological diagnosis is very difficult. Diagnosis is often made clinically in adjunction with radiological features. Treatment of sinusitis. Treatment is in most cases is empiric, targeting the common bacterial pathogens. Amoxicillin plus clavulanate is the first line treatment, even for 5 to 7 days. Alternative drugs include clindamycin or levofloxacin. Sinusitis is a common cause of overuse of antibiotics. Antibiotics are indicated only when specific symptoms are present for bacterial sinusitis such as fever or pleural nasal discharge. When sinus symptoms are suggestive of viral or allergic, antibiotics must be provided and wait and watch policy should be followed. Now, lab diagnosis of URTI, specimen collection and transport, throat swab, oropharyngeal swab containing fibrous exudates is the ideal specimen for pharyngitis. It should be collected by vigorous rubbing of sterile swab over the posterior pharynx and both the